like to get straight into our session because we have 90 minutes, we have 8 speakers, and it's going to be really important that our speakers stick to 10 minutes so that we can have some good discussion time at the end. And so I'm going to be a bit of a policewoman, and at the end of 10 minutes I'm going to hold up this red card. So please take note that you should be wrapping up at that point. So, okay, so we've got a very large room, and so hopefully everybody can take their seat very quickly. Let me get my card out. Mira, would you like to make some welcoming comments to our group?
No, I think what is important is that we want to leave a lot of time for questions and answers. So it would be very nice if people stick to their time and, whatever way you want to do it, but please stick to the time. Don't go beyond the time. We wouldn't like to show you the card, so why don't you control yourself, yeah.
Okay, so I'm just turning up the page.
Yeah,
Here we go. Okay, so this session is the changing landscape of tobacco control. So we have some excellent presentations from China, from Bangladesh, from India, from Russia, and it covers a whole range of issues that really are contributing to the changing landscape. So I'd like to welcome our first speaker. Now, this is really interesting. Our first speaker is Sushanti Singha. Do take your position over there. Sushanta Singha is a journalist. He's from Jamuna TV. He's had some BI grants and has done some excellent work. And he's also been to a John Hopkins training session on tobacco control, or training course, I should say, on tobacco control. So over to Sushanta, please. Thank you.
Thank you. Good afternoon. Welcome to all of you in my presentation. Title is Child Labour in Bidi Factories, Current Situation and Way Forward. As you know, Bidi is a local handmade cigarette, and among the smoker, 11.3% of Bangladeshi smoker use Bidi. Before going to my word presentation, I want to share with a visual documentation. I hope it will be help you to understand the real scenario of Bidi industry and also the child labor situation.
It would be so difficult for them to remember which paper. Well, we can ask one question.
It's not working?
The IT person here. Huh?
Here we go. Good. Can we check with our IT person at the back that this is working for us?
They said it automatically gone. No.
Can you start speaking a little bit,
Here we go.
thank you for watching. About 65,000 direct workers working in the 117 BD factories across the country, and there are some associate laborers. Most of them are children. This statistics is 220,000 in the Bangladesh, and most of them are the child. In this context, it is important to explore the child labor situation in BD factories to highlight the need for regulating this harmful sector and to stop child labor. This is a dual purpose research. The overall goal and objectives is to reveal the child labor situation in BD factories in Bangladesh and recommend the ways to regulate this sector through stopping child labor, and more specifically to collect information about the current scenario in BD industry and child labor, to examine the reason or facts behind the child labor, to collect information on education, economic and health status of those children and their family members, and to recommend the policy measures to regulate these BD factories through stopping child labor. In study area, this is Bangladeshi map. We conducted in the 4 areas, the highly concentrated BD factories area in Bangladesh, Rangpur, Kushtia district, and Tangail and Borishal. And each area we took 2 factories, as a whole 8 BD factories. We conducted survey in our research process. It's a mixed method questionnaire survey. We took 320 total questionnaire survey. Among them, 160 child are aged 7 to 14 years, and we also took the interview questionnaire survey of 160 caregiver or parents of those children to get some information from their family members. We select conveniently based on availability on their household area, and also a key in-depth interview we took because we need some additional information from the side of factory management, health workers or health professionals and doctors also, and senior members who are working at least 10 years in the BD industry. Findings, we surveyed those children who are the 58% are boys and 42% girls. This is the information is important for us that 42% girls are working in the BD industry and 68% their age is 11 to 14. Though we select 7 to 14 years old, we get less than 7 years in the factory available in all over the Bangladesh. 70% of the parents of those child laborers are found to be illiterate, and 78% laborers belonging their family members 4 to 6 members. Findings, household income is very poor. About half of the households, they have monthly income less than 5,000 taka, equivalent to only 62 US dollar per month their income. And another 30%, they can earn 5,000 to 10,000. It is less than 120 US dollar per month. That is the hardcore poor in Bangladesh. In our findings, near about half of the child working 2 to 4 years and 26% were working 5 to 7 years. Among their age of 7 to 14 years, they are working 5 to 7 years. So we can guess their early acceptance in the factory. Number of the working days is varied across the country. Most of the work 1 or 2 days in Bangladesh, but except in Kushtia, we found the 6 days in a week factory is running. 68% child working during the first half of the day, which is usual their school time, and working hour 42% child work more than 6 hours per day, and another 37 they work 3 to 6 hours per day. Amazingly, we didn't see not a single child they use protective gears like masks or gloves from the tobacco hazard. Whereas BD laborers are the least paid workers in the country. Among them, 46% child earn less than 30 taka. That means not a $50 per day. And another 60% child, they get less than, and around 61% child get less than 50 taka. That means 65 cents per day, working 6 hours, more than 6 hours with a hazardous condition. 9 out of 10 children, they input their income to their family, though it's very little and very poor amount. We try to find out the reason and facts behind this child labor. Low wage rate and the employment only 1 or 2 days in a week is less attractive for the adult workers. Lack of awareness about the adverse health impact of working in BD factories in the family members, parents or caregivers. Child start working at the factories with their mothers. Trade union is found to be a good instrument to limiting the child labor, and lack of law enforcement may aggravate the situation. Findings in education sector, we found that 24% working child are out of school, some dropped out, and 74% responded that reason is work in the BD factory for dropped school or out of school. In the health condition, 8 out of 10 workers have pointed that they felt sickness in the working time in BD factories, and commonly they told us that vomiting, breathing problem, headache, cough, waist pain, fever, abdominal pains, etc., etc. It's a good news for us, but bad news for them. 76% child wants to quit this sector, but they couldn't because of their poverty. In policy recommendation, that is our first policy support, that we told that special social safety net program can be addressed to the highly BD factory concentrated area, because Bangladesh have a 142 social safety net program. So if we want to give them any social safety net support, then it will be helpful for them to quit this job. And necessary policy measure and enforcement of existing laws and regulation is vital to prevent the child labor in BD factories. When we took the in-depth interview on the senior workers who are working at least 10 years, they said not a single law enforcement agencies come to the factory and they overview this situation. They come only 1 or 2 in a year to meet the factory management and take some money or bribes, and they go to their office. And parents need to be aware of the adverse effect of working at BD factories. Government, media, development partners should work side by side to stop child labor at BD factories, and detailed survey need to be carried out, because in Bangladesh we don't have enough solid database. So this is my second research. In first research we did a quantitative survey, that is the child labor and other labor situation. So we urge that the detailed survey can be a good instrument for protecting our child from tobacco. This is another snap. If you found, there are lots of kids working with their family members. Thank you for patient hearing.
Thank you very much, particularly for keeping to time. Do we have just one quick question at all, clarifying question? Okay, thank you. Thank you very much for that. Our next speaker.
He has a question.
Oh, sorry, there is a question. Sorry about that. Yes?
Yes, thank you. It's very interesting, very touching presentation actually. I would like to ask, you said over 140 safety net programs are there.
Yeah.
And why are these children not in any of these safety net programs? And what we see is that because they are dropping out of school, this is a vicious cycle. The reason why they're in the first place is because their parents are illiterate.
Yeah.
Now the children are unable to attend school, so it would continue. So why are they not in the safety net in the first place? And the second clarification, just a question is a media question. Have you tried to highlight this in your particular media organization to the public?
Yeah, of course, the last question I am answering, I am a member of ATMA, Anti-Tobacco Media Alliance. We have more than 300 journalists according to around Bangladesh, and we meet together each and every month, and we took initiative to how we will expose this tobacco hazardous job and this type of things. So we are trying, and we get some benefits. And first question of you, the social safety net program, there is two kind of things, because the BD industry owner, they are always misleading that Bangladesh has a 25 lakhs or 2.5 million or 1.5 million workers. They are staying, and they are the poor people. If government take any steps to them to raise tax or this type of things to regulate the BD sector, they will be lose their voter. That is the one question. And another issue is that the government don't have enough information. This is the first research on the issue, so it will bring some question on the issue of their rights and their social safety net programs. We are trying to push this research to the policymaker that we can introduce this type of social safety net program for those children. Especially government feel that they will lose their vote because they are misleading. As I earlier mentioned, 2.5 million workers are working in this country. When I did the research on 2012 by the CTFK funded, that time we found only 65,000 direct workers are working in this factory. That time our finance minister took these books, and also our anti-tobacco media campaigner, some of them are here, they provide these books, all the parliament member, then it's come to down and they are shifting their language. So we are trying to do something for this sector. Thank you.
So the second speaker is
Thank you very much.
Gopal Chauhan. He is going to speak on who is accountable for tobacco control in India. Critical analysis of stakeholders. Gopal, can you say in 2 sentences what you do?
Yeah, thank you, Chair. Currently, I am working as a state nodal officer for NCDs, non-communicable diseases, in the state of Himachal Pradesh. Previously, I worked as a state nodal officer for tobacco control in Himachal Pradesh in India for 7 years. Something that we in Himachal Pradesh, we are the first, smoke-free state in India. And I am always inspired by Meeraji and Madam Joan. Madam, should I continue now?
Yeah, please.
Thank you. This is about the conflict of interest. I have no real or perceived conflict of interest that relate to the presentation. Now coming directly to my presentation. Currently, we all know that M-Power is the possible solution for tobacco control. In context of India, I say that we are trying to implement as comprehensive M-Power, but still we are at initial stage. But currently we know that M-Power is the possible solution. And what is happening, the implementation of M-Power, because health department or health ministry in India is a nodal agency for tobacco control, meaning thereby, on the analogy of WHO, meaning thereby health department has the responsibility to implement M-Power in India. India as an obligatory to the global FCTC with multiple challenges including high prevalence of tobacco use, and more important is the variety of tobacco products, because I think we have hundreds of variety of tobacco products. If we see now in context of our policies, in India we are implementing national legislation of tobacco control, that is Indian Tobacco Control Law 2003, and we have a national program that is known as National Tobacco Control Program, NTCP. If we do analysis, we can say that these two programs and this law is covering partially P, W and E component of M-Power, but not MOR component of M-Power package. Now we can see that instead of a policy, instead of a legislation, and in spite of a program, we are covering half of the M-Power package. These policies involve multiple stakeholders, and all M-Power tools are not within the purview of Health Ministry. This is what I wanted to say, that if Health Ministry is given this task, Health Ministry should have a stake on all components of M-Power. But why it is not so? My study is, this is some sort of a analysis of the stakeholders by IPA, in which I have tried to find out who are the stakeholders, what are their strengths and weaknesses in relation to M-Power implementation. IPA, interpretive phenomenological analysis, is a qualitative approach to identify the shared interest, experience, scope of the stakeholders. What I identified, the key stakeholders in tobacco control are health ministry, NGOs, researchers, media, police, judiciary, trade and commerce ministry, information and broadcasting ministry, finance ministry, and agriculture ministry. Now you see, in context with Empower, when you see that what are their core functions, we see that if we relate health ministry with Empower, health ministry has adequate scope for monitoring tobacco and offering help to quit, but very limited scope as a law enforcer to protect people, to ensure pack warning, taps ban, and to raise the taxes. Why it is so? Because they fall in the domain of other ministries. Other key stakeholders are NGOs and researchers are the key for policy advocacy and analysis as far as the literature is concerned and the practice is concerned. Media is almost neutral. Police not being the prime stakeholder, they are contributing more for law enforcement in India because this tobacco control law has to be enforced and mainly police is enforcing throughout the country. Judiciary support is tremendous. Ensuring pack warning and regulating tobacco advertisements are within the purview of Trade, Commerce and Information and Broadcasting Ministry in India, not with the Health Department. If we want to regulate this industry, if we want to ban tobacco advertisement promotion, if we want to print those pack warning in the tobacco packs, it does not come within the purview of Health Ministry. And rising tobacco taxes, which is one of the most important tool in tobacco control, it falls in the domain of Finance Ministry. Okay. Agriculture Ministry, the prime focus is to safeguard the interest of the tobacco farmer. Now you can see that how in India we can implement this Empower package with the limited scope of Health Ministry. Last, I would like to say that if we want to implement comprehensive Empower, we should not rely on Health Ministry alone. Because I told you that we have as a Health Ministry, we have a limited scope for all the Empower tools. And we should have, what we recommend, we should have a national level statutory regulatory body with sufficient control on all the relevant stakeholders for effective tobacco control, because it may be a commission, it may be a regulatory body like Food Safety Standard Authority of India, it may be Tobacco Regulatory Authority in India. But if we rely purely on Health Ministry, I don't think that we can implement Empower. Why I am saying, because from the state where I come, we are trying to develop a Empower model for the state. We have, declared on evidence basis our state as the first smoke-free state in the country. Now we are going forward for the comprehensive Empower package, and we are finding these difficulties. So we conclude here that we should have a statutory regulatory body at national level. Thank you very much.
One burning question. Anyone want to ask? Yes.
Dr. Gopal, I think it is a very pertinent analysis of various stakeholders. What is the role of the stakeholders? In addition to it, can you further extend this study for what is the role versus what they are doing? Because although Health Ministry has a role in 3 components of Empower, but what proportion of work has been done by the Health Ministry as compared to the other ministries? Because this is important in this context, because despite we have 3 components, the prime stakeholder and the prime role is still played by the Health Ministry and not by the other ministries in our country. And I think similar is the situation in other countries. So have you tried to analyze further that the proportion of role played vis-a-vis what is the role assigned there?
Not yet, sir, but we can do it further, because why I was doing this analysis, because whenever we are going for a comprehensive Empower, for example, we are trying to raise the taxes on tobacco, okay, and versus, you can say that offering help to quit tobacco. If we want to go for more tobacco association centers, or if we want to raise awareness, directly we have to pass order from the Health Ministry. But in case of rising tobacco taxes, okay, you have to move to the Finance Ministry, and the key focus of Finance Ministry is to raise more funds. If we say that, The first argument comes, you all know that when we say that we have to increase taxes for reducing consumption of tobacco, they say that we will be losing this much of amount. But sir, as you rightly said, we need to do further study on this to take that what really they are doing exactly right now. But currently we don't have. We will surely go for that. Thank you.
Thank you. Thank you very much. I think we need to move now to Sandy Mullins. Is Sandy here? Sandy's the Senior Vice President at Vital Strategies for Policy Advocacy and Communication. So she's a communication expert with many years' experience, and it's a good segue from our presentation from China, because it's about how you can use mass media to support tobacco control laws and enforcement, and the case study is Vietnam. Thanks, Sandy.
Hi everybody. Thanks for letting us do this presentation. I will say in advance that this is actually a presentation put together by Tom Carroll, one of our senior advisors who's based in Melbourne, Australia, but has done a great deal of work in Vietnam with partners on the ground. So Tom could not be here, and I'm doing this presentation on his behalf. So do I move my own slides? Okay, great. So just a bit of background about Vietnam, which is probably familiar to many. Hi, Bill. As you can see here, Vietnam has one of the highest smoking prevalences among men in the world, and a huge burden from smoking-related disease. But good news, Vietnam passed its first comprehensive tobacco control legislation, so there's certainly great progress being made there, and you all may also know that it has also started its own health promotion fund, so we're very pleased with some of the progress that we've seen in Vietnam. We have been working there for a number of years now, almost 10 years, and our role in the Vietnam work is to help to put together strong mass media campaigns that both warn people about the dangers of smoking, the dangers of secondhand smoke, as well as to try to push policy efforts. And I think that we've strategically tried to work with partners to time the appearance of campaigns around some of their important policy pushes, certainly around the national law, around the new pack warnings that are also in place. And I'm going to show you a few of those examples of television spots that we've been able to help put on the air there shortly. This is just to mention that the details of the graphic pack warning, the details of the laws that we've been involved with trying to push. And as I mentioned before, the new pack warnings that started in February 2014, and introduction of smoke-free regulations in public places that started in December 2013. So this is a bit of detail about the campaigns. I won't go into great detail here, but essentially one thing to note, and this is something that I think Vital Strategies, formerly World Lung Foundation, has really tried to promote in all of our work, which is that if you have a good piece of communication material that is made in one place, it can be quite easily adapted to another environment. So by changing the tops and tails, by changing the language, by changing some of the shoots so that the people are localized, you can take a good concept and make it work very well in other places. So the campaigns that we've taken were actually originally developed in New York City, and I think, for example, the Cigarettes Are Eating You Alive and Baby Alive campaign have been run in about 20 countries at this point in different languages. So it certainly saves a lot of time, money, effort on creative development, but the rule is you have to test it very, very carefully in a local environment to make sure that it works with local culture. So I think the ad, I'm told, will play by itself. There should be sound.
Và mô bào của cơ thể, tim, phổi, kể cả miệng, răng và cổ họng. Hút thuốc dẫn đến cái chết từ từ và đau đớn. Các tác hại của thuốc lá này đã được thể hiện rõ trên bao thuốc. Hãy bỏ thuốc ngay hôm nay. Từ ngày 31 tháng 12 năm 2013, hút thuốc trong khu vực cấm sẽ bị phạt từ 100.000 đồng đến 300.000 đồng.
So I know most of you don't understand Vietnamese, but I think hopefully the images tell the story quite vividly. I'll just go right to the next one.
Từ bên trong, hút thuốc sẽ gặm nhấm hầu như mọi cơ quan quan trọng và mô bào của cơ thể, tim, phổi, kể cả miệng, răng và cổ họng. Hút thuốc dẫn đến cái chết từ từ và đau đớn. Các tác hại của thuốc lá này đã được thể hiện rõ trên bao thuốc. Hãy bỏ thuốc ngay hôm nay. Từ ngày 31 tháng 12 năm 2013, hút thuốc trong khu vực cấm sẽ bị phạt từ 100.000 đồng đến 300.000 đồng.
So the point there being that the mass media campaigns that we ran in conjunction with this reinforce the packs that are being used, that are being picked up and in people's hands. I'll show you just one more.
Em tiếp xúc với hàng ngàn hóa chất độc hại đang tàn phá cơ thể các em từ bên trong. Khói thuốc chứa độc tố như phóc-môn và carbon monoxide làm tăng nguy cơ gặp phải các vấn đề nghiêm trọng về sức khỏe như viêm tai giữa, hen suyễn nặng và bệnh phổi chết người. Khói thuốc còn là nguyên nhân sinh con thiếu cân và tăng gấp đôi nguy cơ trẻ sơ sinh bị đột tử. Các tác hại của thuốc lá này đã được thể hiện rõ trên bao thuốc. Hãy bỏ thuốc ngay hôm nay. Từ ngày 31 tháng 12 năm 2013, hút thuốc trong khu vực cấm sẽ bị phạt từ 100.000 đồng đến 300.000 đồng.
Okay. So one of the things that we think is extremely important, and I know that many colleagues here agree, is that you have to evaluate what you've done to make sure you know whether it's had impact or not, and also whether you need to do something different the next time around. So this is the methodology that we use to evaluate these campaigns, and the survey sample, the evaluation was done in several cities in Vietnam. And what we found is that there was quite good population reach, 63% prompted recall and 63% among smokers. The data there shows that it seemed to have quite high salience in that 87% of smokers said that the ad made them feel concerned, 79% said they were likely to comply with smoke-free regulations, 69% that it would more likely make them stop, 62% make them more likely to quit, and 75%, and this is something that we care a great deal about, what kind of, not just attitudinal shift, but behavioral shift might we see, that 75% reported making a quit attempt as a result of the campaign. And then lastly, the campaign was also had high reach among non-smokers, and not surprisingly, or we were pleased to see that 97% said the ad would make them more likely to support smoke-free regulation, 77% more likely to complain about being exposed to secondhand smoke, and 75%, interestingly enough, said the ad would try to make them persuade someone to quit smoking. So just a few takeaway slides from the evaluation that we did, which is that the mass media campaign seemed to reinforce the communication from the graphic pack warnings, that they influence both smokers and non-smokers' intentions, and they also created support for the implementation of tobacco control smoke-free policies, and lastly, but very importantly, they prompted quit attempts. So that's my presentation. I'd be happy to answer any questions.
We don't have time.
Thank you. We only have time for one burning question, otherwise we will have a couple of minutes at the end. Any clarifications? No. Okay, thank you very much, Sandy. That's great.
Dr. Gupta, he's going to speak on impact of ban on smokeless tobacco products on tobacco consumption behavior in Punjab. I think this is very important that we already have the results,
Yeah.
Of the impact. Okay.
So, I'm Dr. Rakesh Gupta. I'm State Program Officer for Tobacco Control Program in Punjab. The prevalence of tobacco use in Punjab is about 11.7%, and out of that 6.5% they are actually using smokeless tobacco. And all over India, out of 35% prevalence, almost 26% they are using smokeless tobacco. So you can make out how important it is to ban and actually implement the ban. Yeah, next. Okay. Out of it.
Can our technical person? Okay, thank you.
Yeah. So there are in India actually there's Food Safety and Standard Act, and under which we have banned this smokeless tobacco. In 2012, Commissioner FDA of Punjab he banned the gutka. Actually, gutka is a combination of pan masala and tobacco. In India, unprocessed tobacco is not banned. It is not banned, and only the smokeless, the gutka, which contains tobacco, and pan masala. Pan masala is combination of many flavoring agents plus tobacco, plus supari or areca nut. In 2015, flavored and scented tobacco was also banned in Punjab, but there was a lot of resistance from tobacco industry. And when this notification was issued, the manufacturer of that flavored tobacco was allowed, but under pressure from media, they had to insert that line of banning manufacture as well. The ban has been in place since almost 4 years, but implementation is an issue. So I think we need to assess, we felt the need to assess the impact of ban on smokeless tobacco products on tobacco consumption behavior in Punjab. The methodology used was 450 currently tobacco users from 3 randomly selected districts of Punjab. This study was conducted in collaboration with PGI Chandigarh. A pre-structured questionnaire consisting of 50 questions, quantitative and in-depth interview of 45 tobacco users, qualitative. The respondents were enrolled from points of sale in urban as well as from the rural areas. So among a total of 450 tobacco users, 170 were reportedly using smokeless tobacco, out of which 42% was concerned about, actually they were concerned about the ill effects. So of the current users, 80% they were in contemplative phase and 38 were in post-contemplative phase. A majority of users had knowledge about the ban and supported the ban on smokeless tobacco, but there was easy availability of smokeless tobacco all over Punjab, in all the districts. So conclusion is, due to the awareness drive by the Food and Drug Administration, India, there is a considerable knowledge about the ban and harmful effects of smokeless tobacco. However, it is available at most of the points of sale, and there is an urgent requirement to take punitive action under Food Safety Act against the violators of ban on SLT. So I may add that we are, in addition to the World No Tobacco Day, in Punjab we are celebrating Punjab No Tobacco Day. That is on 1st November, that is fast approaching. And what we have done is, so we are focusing on implementation of the smokeless tobacco. So 1st to 7th of November, special campaign is being launched to implement the ban on smokeless tobacco. We have 45 food safety officers. So all food safety officers, they are supposed to take at least 5 samples of smokeless tobacco each month. So that makes about 225 samples in a month. So I think when food safety officers, they start implementing this, so it will be, the impact would be much great. Last month, in September, in the month of September, we had 119 samples, and out of which 80 they had tobacco with flavors. So action would be taken. The court cases have been launched, and action will be taken under Food Safety Act. So that's all. Thank you.
Yeah, since he's finished so quickly, I think we can allow one question. He's finished very quickly. Any question?
Can I perhaps ask a quick question? Is there, in all this this challenge of enforcement, is there any mass media that's helping to reinforce what the law is.
Yeah, we are lucky that all the stakeholders in Punjab, in tobacco control, they are on board. Like I said, the PGI, we are collaborating with the PGI for the studies, and we have civil society. We have representation from the Generation Savior, Ms. Upenda, she's with us. The media is also very supportive. We get lot of earned media support. Mr. Mishra, Deepak Mishra is with us. He's a media expert. So all over India, not only in Punjab, all over India we get a lot of support. And I think the ban on SLT, pan India almost, that is because of the result of the media support.
Okay, thank you.
Yeah,
Please thank our speaker. We have, I think we should push on, and we have 2 more speakers. Thank you very much.
Thank you.
Pranay, yeah. How many deaths can be averted by increasing the legal age at initiation of 21 years globally?
Thank you, Chair.
Please say a few words about your work.
Right. Thank you, Chair. My name is Pranay Lal. I work with the International Union Against Tuberculosis and Lung Disease in New Delhi, India. I'm a biochemist and a virologist by training. I'm going to talk about something which is about looking at elimination or eradication or planning for an end game in terms of a global implementation. I'm looking at one of the options that is being exercised in some developing countries. I'll go straight into it. One of the strategies that has been suggested by developing countries, especially last year, in 2015, the Institute of Medicine in the US, in Washington, D.C., came up with a seminal report on looking at raising the age to 21 years. And several counties and cities in America and 2 states now have raised the age to 21 years. It's fascinating the kind of work that is happening globally. There's one state in India which has the lowest prevalence of tobacco use. In that state as well, the state of Goa, the age of tobacco use and purchase is 21 years. So there's a lot of evidence from across the world that prevalence of tobacco use decreases if the age of use and purchase is increased. But let's see what happens if it were to be raised globally. And I've developed a model for 2 scenarios. And I'll just take you through quickly what is the possible way to look at a scenario for eliminating tobacco use through the application of age of 21. Now we know that early initiation of tobacco use creates hardcore tobacco users, hardcore smokers. The younger you start, the stronger is the addiction. And we also know that when you are a hardcore smoker, you are unable to quit, and the quit rate relapses are significantly higher. We know that in many developing countries and developed countries where tobacco control has progressed, there has been a decrease, or tobacco use prevalence has kind of plateaued. And in such a business as usual scenario, what is it that we need to do to break this inertia? Right. We have some evidence historically from alcohol use policy, and I think several good case studies when age of use has been increased from 16 to 18 and 18 to 21, and then in several countries from 21 to 25. Many of these countries are the US, Canada, Portugal, Italy, and Australia. Now, we know that if age of initiation is moved from 18 to 21, we would reduce a significant proportion of people who would become potentially lifelong smokers, and there would be fewer hardcore smokers. Now, so therefore the rationale, I think I've explained this, I will skip this slide in the interest of time. There are several data sets to choose from, but each of these data sets has limitations and some data gaps which prevent us from using it comprehensively. For this study, I don't know if this has a pointer, but okay, it does. Okay. I've used the World Population Prospects database of 2010, which is produced by the United Nations ESA, and the WHO report that came up with the 2015 and 2025 projections of tobacco use, smoking actually, cigarette use, cigarette smoking. And this is called the WHO Comprehensive Information Systems, or the CIS. There are several other databases like the IHME, the World Bank Global Adult Smoking Rates. There are GATT surveys which are pretty representative, especially for age-wise data sets. The actuarial data is excellent, but it's you don't get life tables and survival curves for several countries, and that's a bit of a problem, especially if you want to look at, if you want to build a prospective cohort of a current population over the years, especially starting from 2015 to 2060. Let me not, so basically the use of data set, the one I'm pointing to now, and this one is what we have used for our study. Currently, for the age of 21, these are the following models that have been used so far. The IOM report had developed a model using the SimSmoke model, and that's a very robust model, as many of you know. There's also there are two studies, one done by Nick Wilson and another by Chase, which uses the Bayesian model. Again, because both Australia and New Zealand had excellent data for about 2 decades, they were able to do this and forecast future tobacco smoking rates in both those countries. The actuarial models, the Citibank report that came out in 2014 had used the actuarial model. I have a bit of question mark because they have kind of generalized it for many countries, and there's a bit of a question with that. The Lives Saved tool is something that the UNICEF has developed. It's an excellent package. Unfortunately, we have huge data gaps, and we therefore need to bridge those data gaps before we can start using this model. So basically what I have tried doing is looking at the IOM model, and I've tried using the data from the UN ESA and tried using it in LIST model. Let me try showing it to you what I mean. What we've tried doing is that looking at if there are no other complementary strategies that are being implemented other than raising the age to 21. And we continue with the business as usual for across the world. What is going to be the effect on smoking prevalence? One of the things that we do is look at the use age prevalence data for each country, and we look at it as a representative for both at the lower interval as well as the highest interval. What this means is that we look for prevalence in 13 representative countries for which we have robust data. And these are representatives for each of the regions for which we are going to work this model. We look at points in which we look at increments of prevalence in lifelong users, and from the age of 15 to the age of 18, and we see how that increment shifts from 18 to 21. We also look at quit rates and relapse rates, because we have this from both GATS and from several country studies. So the 13 that have added up here include both GATS studies as well as country-specific studies. So we tried developing it through two scenarios. The first scenario is that there is a 10% reduction at the year in which 2015, which we have taken as a cutoff year, in which, say, hypothetically, if we were to introduce age of 21 reduction. Now, if we were to introduce reducing age to age of 21, what would be the reduction in subsequent years? Okay? And if we were to look at the best case scenario, I mean, if there was perfect implementation and all vendors were to comply, not selling it to minors, especially from the age of anybody below the age of 21, what would be the reduction? So here's what we get to see. So just trying to show you the data sets first. This is the UNESA model, and you have it for each country. You have, here is the number of people of different age groups by age intervals. And you get this for each year for 2014, 15, 16, 17 till 2070. And this is the prevalence model of the WHO CIS report that I told you about. It's a massive database, excellently developed. And I think if both these are used alongside, these are the results you get. Now, this is what the WHO's 2015 estimate says about, this is what was the baseline they used, and they found as business as usual, in 2025, this would be the prevalence by continent. Now, when we run our model for worst case and best case, this is what the reduction in prevalence happens. Now, there is no reduction in prevalence for the first, in the first 10 years after 2015, from the year when we start counting the prevalence rates. There is no reduction in Afro, but it starts declining, and by 2050, there is a perceptible difference, and this happens across. If you were to run these numbers, now the critical driver here is it's business as usual. We are not looking at taxation, we are not looking at anything else. The other tobacco control policies are kept the way they are. They will work by themselves. But the only intervention that is happening globally, if it were to happen, we have looked at age of 21. And we've looked at those two scenarios, the best case scenario and the worst case scenario, like I mentioned earlier. So if you were to look at these numbers here, the worst case and the best case scenario, look at the decline that happens by 2050 if you were to look at the natural extinction of the number of people who would not be able to access cigarettes or tobacco products in that case. Several people have suggested that tobacco industry is not going to oppose, and we are seeing this in America also. Tobacco industry generally does not oppose any such measure as increasing the age to 21, right? Even in my country, when the state of Goa put it up as age to 21, there was very, very little resistance. We therefore think it's kind of tenable for us to propose that if a global consensus is drawn, you could look at an end game which is viable. Now, the reason why you want to position something first as an end game solution, a pre-step to an end game, is because you want to start telling the population that tobacco, the denormalization process of tobacco among the population of 15 to 21 begins with the fact that you're no longer able to buy tobacco at the age of 18. So you have a significant cohort which will move on every year, adding every year. And therefore you come to a position where the prevalence drops so low that there are very, very few people in the future who will smoke or use tobacco. Now, coming back to this slide, if you were to look at this natural extinction rate, whether in worst case scenario or the best case scenario, in the best case scenario, we find that by 2064, there would be virtually no smoker in the world. There would be an extinction, right? Even if you were not to implement, I'll just take another minute. Even if you were to take business as usual scenario, but adhering to the fact on the worst case and the best case scenario, you would have near extinction by 2064 in the worst case scenario, in the best case scenario, and 2072 with the worst case scenario. So it is something that is imaginable, at least speaking hypothetically and using mathematical models, to say that there will be a natural extinction in every region where you're seeing a very, very high prevalence. Look at this. I mean, these are amazing prevalence rates if we were to look at it 2025. Look at Afro, look at Emro, and Sierra. Sierra stays, the population is going to increase manyfold, and this is going to be something which is going to be unsurmountable. So this is my conflict of interest. I have no investments or any other interests in tobacco industry. Thank you so much.
Don't they say that if the age is increased to 21, there is only 5% chance that anybody will, take to smoking?
Ma'am, there are two studies which actually say that, but tobacco industry is the first one to counter it. But I don't think we should give them that evidence, give them the opportunity to address that evidence at all, because I think they are not going to oppose it anyways.
Thank you, Pranay. I think we'll hold any questions. We only have one more speaker. So thank you. And our last speaker, is Irina Morozova, also from Vital Strategies, also a communication expert. and she is going to tell us about the cost effectiveness of the mass media campaign in Russia. Thank you.
Hello everyone, I'm very happy to be here. First, I work with Sandy, and our international team assisted governments in more than 33 countries, I believe, to run more than 170 tobacco control campaigns, which has reached more than 2 billion people across the globe. And you saw one campaign from Vietnam, and I'm going to show and talk about the other campaign from Moscow, Russia. And this is the second reason for me being really proud, because I'm Russian myself. I was born in Moscow, so it was a really personal deal for me to assist Russian government running this municipal level campaign. And the next just introduction, I'm a mathematician by my first background. And that's why for me the numbers make real sense. And Sandy mentioned a lot about how we evaluate campaign. It's really, really important to change knowledge, to change attitudes, and to break to changing behaviors. But what's really possible with knowing some formulas, how to estimate the other side of impact that campaign gives us, life saved, years of life saved, and to have these numbers to bring to the governments and advocate for more money to invest into tobacco control communication. So some background about the campaign. I have the same difficult. So this is Russian campaign. You see snow. I mean, just to start with. And it was a sponge. I understand that not everyone is an economist. Who is economist or deals with just few people probably, right? Probably the previous speaker related. But how many of you work with public health? Everyone, right? So I hope that at the end of the presentation, you can take away with you this conclusion and to bring with you to the governments you work with to advocate for, again, for sustainable fundings for tobacco control communication that look expensive, but in fact, at the end, it's really worth spending. So about the campaign, it was Sponge. For me, it's iconic campaign, the same as maybe for tobacco industry, Cowboy Marlboro. Who did not see this campaign, and I have to show it? Sponge? We're in trouble, Cindy. So I'm going to show. And the budget was quite modest. It was $200,000, but again, it was a municipal campaign, not a country population campaign. It ran for 2 months around Quit Tobacco Day, which we have in country around November. It's a kind of anchor event to World No Tobacco Day in May, and it's a good event to engage media, to remind them that how important that fight with tobacco. And it ran on TV, street billboards, in metro posters. And you know that probably Moscow subway is not just the most beautiful in the world, in the 5th in terms of capacity. So during the peak months, it ran every day more than 9 million passengers per day, and on average it's 6 million. That's why having this modest budget, it was really strategically. We understand that TV is the primary media, but it was so expensive. Just to give you an example, 2,000 GSP or $2,000 per 1 GSP. So we're not able to afford a lot of TV time. So what we did, having on board and Moscow Duma, it's a kind of state council, Commissioner of Public Health, we made an arrangement with the owner of Subway Metropolitan and strategically placed these big posters where the people changed their lines. So we did not have a lot of posters there, and the same with the streets, but they were really placed strategically. And this is the ad. Oops.
Легкие человека впитывают воздух как губка. В табачном дыме более 4000 ядохимикатов, больше, чем в выхлопных газах автомобиля. За год в легкие человека, который выкуривает пачку сигарет в день, поступает около 150 мл канцерогенных смол. Курение – причина рака легких, бронхита, эмфиземы. Каждая сигарета опасна. Откажись от курения сегодня.
And what I like about showing the ads really without subtitles, I understand that maybe some of you speak Vietnamese, yeah, from the previous, but how many of you speak Russian? And still, I'm sure it's quite clear, right? It's about what comes into with the smoking, how our lungs of smokers accumulate and pass through. And this is the amount of tar that goes into the lungs every year for average smoker, which smoke 1 pack a day. And so the campaign, when we evaluated the campaign, among other questions, we asked how many people saw any anti-tobacco any cessation messages during the last couple of months. And 65%, we asked 1,000 people, it's the standard for this type of evaluation. 65% remember some type of anti-tobacco advertisement, but what's good, every second, more than 50%, recall sponge, and we call it unprompted recall. And try to remember this number in red, because we are going to use it later on. And we also learned that among those who were aware of the campaign, not just saw, but saw and remembered the message, right? 24% tried to quit smoking. And among those who said they did not remember the campaign, maybe they saw, they just don't remember, the message did not resonate with them at that time, only 13%. So we are going to use this number again later. And we have a very strong research and evaluation department in our team, and Nalin is here, so thank you very much for his help. And they developed a standardized methodology how to evaluate campaign effectiveness in terms of deaths averted, lives saved. So what was done? What was the model? Compared quit attempts in status quo without the campaign, how often people try to quit smoking without being exposed to the message, and compared with those quit attempts generated by the campaign. Then we checked how many successful quitters were among those people, and if they applied tobacco user health burden or the budget. So when we recalculated it with the real number, I know that we are very short of time, so I'm going just to go to the conclusion immediately, but all the formulas here, Nalin and me here, so if you are interested, please stop by. So what we had, campaign budget was $200,000, 50% unprompted recall, 24 versus 13% quit attempts among aware and not awares. When we recalculated Moscow population, and based on the ratio between smoking Russian population and Moscow smoking population, we recalculated how quit attempts campaign would generate it in Syria. It was more than 2 million. Then we know from secondary data, and it's a very conservative estimation, that among all those quit attempts, at least 2.5% are successful. There is no relapse during the next year. So we applied that number, and we got successful quits more than 56,000. And then we applied, then we also know that smokers are at higher risk of premature death, 33% risk. Also, we know that average smoker lives 60 years less than regular person. We applied this number, and we got at the end that it's really like nothing was spent per life saved. Just a little more than $100, $134 per life saved. And per each successful quit attempt, it was really nothing, $44. And there is a data and recommendation by WHO how to formally assess effectiveness of campaign. And it says, if the cost of life saved due to campaign is less than GDP per capita, the campaign is successful. And this is the number, a little more than $8.10. Of course, this campaign was effective. So it enabled me to bring this number, in Russian, to bring to Russian government. And at that time, our Minister of Health, she was an economist by the first background. And of course, they like to hear how the knowledge changed, how the risk perception changed. But when you can bring the number and say, hey, listen, you spent some money and you save lives, it makes big difference. So I just do hope that it was useful for some of you, and if you need the model and all that methodology and explanation how it was calculated, Nalin and me are here, so please welcome, and I hope that will make difference.
Thank you very much. I think that does indicate quite well the changing landscape of tobacco control when we are starting to put dollars on and show the cost effectiveness of the work that we do. I think that's what governments are going to take notice of. So now all our speakers in the front row, because we do have 10 minutes for discussion time, which I'm very happy about. And if anyone would like to ask questions of our speakers, this is the opportunity. And if anyone perhaps wanted to make any comment, short though, because we want to give everyone a chance, about this changing landscape and perhaps what some of these presentations have contributed to. So, yes, Nadia.
You mentioned that there's not likely to be much resistance to raising the age for tobacco purchase. Why do you think that? Because having worked in the alcohol and alcohol harm reduction, we've found there's been a lot of resistance to raising the age.
All right, thank you for, may I, Chair? Thank you for bringing that point to notice. I've been following the US, the progress in US, and looking at how tobacco industry there, and it's quite aggressive, as you know. I've also looked at, if you were to look at the pack warning arguments, if you were to just do a survey, in Government of India, for example, it came as a complete no-brainer to the tobacco companies that they would put, in addition to the pack warnings, that not for sale to minors. Now, it's not mandatory under law. So if you go to Philip Morris's website, they have a dedicated page, and they have a response on age of 21 as well for Philip Morris International. And it's quite innocuous. But if you were to look at something on, say, tax, now in my slide I said it is kind of relative. I'm not saying that there is not going to be a pushback. Of course there's going to be pushback. But I don't think it's going to be as aggressive as tax. It's not going to be as aggressive as TAPS. It's not going to be as aggressive as pack warnings. They're not going to take you to court because they don't want to say that we want to sell to minors or to people. They're going to use the liberty argument, the freedom of choice and all those arguments. But they know that's untenable because several countries have proposed it and it's successfully working there. So I don't think.
We have a follow-up question.
Yeah, I think, well, just following up from Nadia's point too, the industry's always liked associating smoking as an adult behavior.
Yeah.
Because it helps market to kids that are wanting to appear more like adults.
Right.
They'll often make the signs that hang in the stores, not until you're 18.
Right.
Right, and it's their framing. I think in the U.S., the argument, and I don't know if this is relevant to your modeling, but the main argument as it's been presented to decision makers in Hawaii and California is that kids in high school largely get cigarettes from 18-year-old kids that are in high school with them.
Right.
And then I think from the modeling, I couldn't tell, obviously there's different ways you could have done it, but the idea is that will cut off a supply and then delay initiation.
That's right.
And the longer you delay, the argument being, although we're seeing initiation later and later now too, so.
Right. Thank you.
Any other questions? Clarifications?
My question to my question is for a Chinese colleague. Yeah, you have presented in your presentation about you have the term related to illegal smoking. So I just want to learn about what is illegal smoking here. The second point which you have made in one of the slides is the death attributable to smoking. In one of the slides, region-wise deaths attributable to smoking. So is there any database where you can find the deaths attributable to smoking? Yeah.
Yes, I mean, is that what is the definition of the illegal smoking?
I think you use the term illegal smoking here. So what is illegal and legal smoking? I just want to know about, is there any legal smoking too? In one of the slides, you What the second one? The deaths attributable to smoking. So is there any database where the deaths attributable to smoking is present your province wise? Because, have you got this?
I'm sorry.
So the deaths register in China, do you break it down by city or government area? Yeah.
It's no. They only have the listeners.
Okay, we have a question up here. Oh, sorry, we have. Oh, you have a follow-up. Oh, we have a follow-up here first.
Yeah, thank you. Yeah, I was curious to learn. You mentioned about in the Chinese colleague. You mentioned about the industry interference. I understand that the industry, in effect, is Chinese government, right? State-owned, and how for a government campaign. How is the industry interfering? The second question is, you also mentioned that the complaint lines were not used. The public to complain, and any reason why people are not calling that lines to complain about violations? Thank you.
It's the complaint hotline. Each city have a complaint hotline. Maybe the public, a lot of public didn't know, and use is very little. And some cities is very good. Example, the Beijing, Shenzhen is. I think this is the enforcement is very good, and the hotline is very good. So, to answer.
I want to raise a question to the colleague from Russia. I think that your mass media campaign is very successful. You achieved, the GDP increase and very cost effective. But I think that the methodology is a very important thing. One is how do you make the research, baseline research, cross-sectional questionnaire research, so the data is based on self-reported, or you have made a cohort from the baseline and 5 years observation, continue observation, and then you maybe observe the same population from the beginning of your project. So I don't know what's the method. First thing is self-report. So your data based on the self-report. And the second question is, do you observe the same population from the beginning to the final research? These 2 questions. Thank you.
Yeah, I would just say it would be an ideal world of running one campaign and spending, I don't know, 200,000 or million, we can change the population forever. It's not the solution, it's one of the steps to move towards behavior change, right? And luckily we have Nalini who works for our elevation.
Sorry, can I just interrupt for 1 minute? We just have time, we're going to have to leave. We just have one more question over here, and perhaps we can continue this discussion at the end. Just over to Bill Bellew for the last question.
Thanks very much. In fact, I might try to answer that last comment before I make my comment. So from the University of Sydney, we have a research group that looks at social marketing and mass media, and I was really impressed with the results from Russia and the efforts to try to do cost-effectiveness analyses. In terms of whether you're going to use cross-sectional or cohort, it's probably a moot point. You'll probably get the same results. You're right, you'd have stronger evidence if you used longitudinal data, but we rarely have the ability to do that. And we've done enough of this work in campaigns to know the results are going to be very similar. Okay, point 1. Point 2 is the campaigns. When we run campaigns, the end points are not always going to be smoking cessation. There'll be different things, and we won't always be able to make those calculations. But there are other methods that we could use across the different tobacco control campaigns and indeed across other mass media campaigns to look at return on investment metrics. And we've developed that methodology at the University of Sydney and be sharing it shortly. So just to say, we can do it, and I'm happy at a future conference to talk about that. The other thing was, what a great presentation from Pranay Lal. And both that set of data about cost effectiveness and the modelling of what would happen if you raised the legal age to 21 is just the kind of stuff that policymakers need to be persuaded by.
Thanks, Bill, and thanks everybody. I think I'm sorry, but I think there's people beating at the door out here to come in. So I think thanks very much. Please thank our speakers and Myra, our co-chair. Thank you.